Hello everyone, and welcome to another chapter of Advanced Pharmacology. Today, on Unit 18, Therapy of Infectious and Parasitic Diseases, we'll specifically talk about Chapter 69 here. Drugs that weaken the bacterial cell wall, specifically are penicillins. So, penicillins. The introduction. The penicillins are the practically ideal antibiotic because they are active against a variety of bacteria and the direct toxicity is considered low. Allergic reactions are the principal adverse effects. Owing to their safety and efficacy, the penicillins are widely prescribed. Because they have a beta-lactam ring in their structure, the penicillins are known as beta-lactam antibiotics. The beta-lactam family also includes cephalosporins, carbapenems, and aztreonams. All of the beta-lactam antibiotics share the same mechanism of action, the disruption of the bacterial cell wall. So, if we're speaking specifically now on its mechanism of action, to understand the action of penicillin, we must first understand the structure and the function of the bacterial cell wall. A rigid, permeable, mesh-like structure that lies outside the cytoplasmic membrane. Inside the cytoplasmic membrane, osmotic pressure is very high. Therefore, were it not for the rigid cell wall, which prevents the expansion, bacteria would take up water, swell, and then eventually burst. Penicillins weaken the cell wall, causing bacteria to take up excessive amounts of water and therefore rupture. So as a result, penicillins are generally bactericidal. However, it is important to note that penicillins are active only against bacteria that are undergoing growth and division. Penicillins weaken the cell wall by two actions. First, the inhibition of the transpeptases, and the second, the disinhibition of autolysin. Transpeptidases are enzymes that are critical to cell wall synthesis. Specifically, they catalyze the formation of cross bridges between the peptoglycan polymer strand that form the cell wall and therefore gives the cell wall its strength. Autolysins are bactericidal enzymes that cleave bonds in the cell wall. Bacteria employ these enzymes to break down segments of the cell wall to permit the growth and division. By simultaneously inhibiting transpeptidases and activating autolysins, the penicillins disrupt the synthesis of the cell wall and promote its active destruction. These combined actions result in cell lysis, or death. So here is a picture of the inhibition via a penicillin. The molecular targets of the penicillins are known collectively as penicillin-binding proteins. These molecules are so named because penicillins must bind to them to produce antibacterial effects. So as indicated here in figure 69.2, your penicillin-binding proteins, or PBPs, are located on the outer surface of the cytoplasmic membrane. More than 8 different PBPs have been identified. Of these, PBP1 and PBP3 are most critical to penicillin's antibacterial effects. Bacteria express PBPs only during growth and division. Accordingly, because PBPs must be present for penicillin to work, these drugs work only when bacteria is actively growing. Because mammalian cells lack a cell wall, and because penicillins act specifically on enzymes that affect cell wall integrity, the penicillins have virtually no direct effects on the cells of the host. So as a result, the penicillins are among our safest antibiotics. So, the mechanism of bacterial resistance, therefore. Bacterial resistance to penicillins is determined primarily by 3 different factors. First, the inability of penicillins to reach their target, so the PBPs. Second, the inactivation of penicillins via a bacterial enzyme. And third, the production of PBPs that have a low affinity for penicillin. Which brings us directly to the gram-negative cell envelope. All bacteria are surrounded by a cell envelope. However, the cell envelope of a gram-negative organism differs from that of a gram-positive organism. Because of this difference, some penicillins are ineffective against gram-negative bacteria. The cell envelope of gram-positive bacteria has only two layers, the cytoplasmic membrane and a relatively thick cell wall. Despite its thickness, the cell wall can be readily penetrated by penicillins, giving them easy access to PBPs on the cytoplasmic membrane. As a result, penicillins are generally very active against gram-positive organisms. The gram-negative cell envelope has three layers, the cytoplasmic membrane, a relatively thin cell wall, and an additional outer membrane. Like the gram-positive cell wall, the gram-negative cell wall can be easily penetrated by penicillin. The outer membrane, however, is difficult to penetrate, so as a result, only certain penicillins, such as ampicillin, are able to cross it and thereby reach PBPs on the cytoplasmic membrane. Penicillinases are beta-lactamases. Beta-lactamases are enzymes that cleave the beta-lactam ring and thereby render penicillins and other beta-lactam antibiotics inactive. Bacteria produce a large variety of beta-lactamases. Some are specific for penicillins, some are specific for other beta-lactam antibiotics, and some act on several kinds of beta-lactam antibiotics. Beta-lactamases that act selectively on penicillins are known as penicillinases. Penicillinases are synthesized by gram-positive and gram-negative bacteria. Gram-positive organisms produce large amounts of these enzymes and then export them into the surrounding medium. In contrast, gram-negative bacteria produce penicillinases that in relatively small amounts, and rather than exporting them to the environment, secrete them into the periplasmic space. The genes that code for beta-lactamases are located on chromosomes and on plasmids. These genes on plasmids may be transferred from one bacterium to another, thereby promoting the spread of penicillin resistance. Transfer of resistance is of special importance with Staphylococcus aureus. When penicillin was first introduced in the 1940s, all strains of S. aureus were sensitive. However, by the 1960s, as many as 80% of S. aureus isolates in hospitals displayed a penicillin resistance. Fortunately, a penicillin derivative that has resistance to the actions of beta-lactamases was introduced at this time. To date, no known strains of S. aureus produce beta-lactamases capable of inactivating methicillin or its related penicillinase-resistant penicillins. Altered penicillin binding proteins. Certain bacterial strains, known collectively as the methicillin-resistant Staphylococcus aureus or MRSA, have a unique mechanism of resistance: the production of PBPs with a low affinity for penicillin and other beta-lactam antibiotics. MRSA developed this ability by acquiring genes that code for low-affinity PBPs from other bacteria. So, speaking specifically now on MRSA, S. aureus is a gram-positive bacterium that often colonizes the skin and nostrils of healthy people. Infections usually involve the skin and soft tissues, causing abscesses, boils, cellulitis, and impetigo. However, more serious infections may also develop, which would include infections of the lungs and bloodstream, which can be fatal. Like all other pathogens, S. aureus has developed resistance over the years. When penicillin was first introduced in the 1940s, again, all strains of S. aureus were susceptible. However, penicillin-resistant strains quickly emerged, owing to the bacterial production of penicillinases. By 1959, this resistance was overcome with methicillin, the first penicillinase-resistant penicillin. Unfortunately, by 1968, strains resistant to methicillin already started to emerge. These highly resistant bacteria, known as MRSA, are resistant not only to methicillin, which is now obsolete, but also to all penicillins and all cephalosporins as well. The basis of MRSA resistance is acquisition of genes that code for penicillin-binding proteins that have very low affinity for penicillins and cephalosporins. Resistant strains were initially limited to healthcare facilities, but are now found in the community as well. In the US, MRSA is a serious public health problem. In 2014, it was estimated that 75,000 plus infections were caused by MRSA. Not only does MRSA increase mortality, it also increases the costs. Treating hospitalized MRSA patients costs about $35,000 compared with $14,000 for a patient with a methicillin-sensitive infection. Fortunately, the MRSA news isn't all bad. For one thing, although MRSA infections are now common, most patients can also be cured. Also, rates of MRSA infection among hospitalized patients are now falling after rising steadily for many years. MRSA infections that began in hospitals declined 54% between 2005 and 2011, with 30,800 fewer severe infections. There are two distinct types of MRSA, referred to as healthcare-associated MRSA and community-associated MRSA. Of the two, the healthcare-associated MRSA is more prevalent by 80% versus the 20, and emerged earlier in 1968 versus 1981. Also, healthcare-associated MRSA infections are generally more serious and harder to treat. Molecular typing indicate that healthcare-associated MRSAs and community-acquired MRSAs are genetically distinct strains, known as USA 100 and USA 300, respectively. So, healthcare-associated MRSA. Your methicillin-resistant NS aureus was first reported in isolates from hospitalized patients in 1968. For most of the next 4 decades, the prevalence of your healthcare-associated MRSA among hospitalized patients climbed steadily, reaching 85% of all invasive S. aureus infections by 2004. Although many infections with healthcare-associated MRSA surface in the community, nearly all occur in people who have been exposed to a healthcare facility within the prior year, indicating that the acquisition of the infection probably occurred in the healthcare setting and not in the community. Transmission of a healthcare-associated MRSA is usually through person-to-person contact, very often between healthcare workers and patients. Risk factors for acquiring healthcare-associated MRSA include advanced age, recent surgery or hospitalization, dialysis, treatment in an ICU, prolonged antibiotic therapy, and an indwelling catheter, and residence in a long-term care facility. The treatment of healthcare-associated MRSA infections is addressed at length in a guideline, Clinical Practice Guidelines by the Infectious Disease Society of America for the treatment of methicillin-resistant Staphylococcus aureus infection in adults and children. The guideline stresses the importance of selecting drugs based on the site of infection, age of the patient, and drug sensitivity of the pathogen. For complicated skin and soft tissue infections in adults, the preferred drugs are IV vancomycin, linezolid, daptomycin, telavencin, clindamycin, and ceftaroline. IV vancomycin is the preferred drug for children. For bacteremia or endocarditis in adults or children, IV vancomycin and daptomycin are the drugs of choice. Preferred drugs for pneumonia in adults and children again includes IV vancomycin, linezolid, and clindamycin. Because most strains of MRSA are multi-drug resistant, many other antibiotics have become ineffective, including tetracyclines, clindamycin, trimethoprim, sulfamethoxazole, and beta-lactam agents. So that brings us to the community-associated MRSA. Infection with a community-associated MRSA first reported in 1981, and it's caused by a staphylococcal strain that is genetically distinct from the healthcare-associated MRSA. For example, most strains of community-acquired MRSA carry a gene for phantom valentine leukocidin, whereas the healthcare-associated MRSA strains do not. Many people are now asymptomatic carriers of community-associated MRSA. In fact, between 20 to 30% of the population is colonized, typically either on the skin or in the nostrils. Infection with a community-associated MRSA is generally less dangerous than with a healthcare-associated MRSA, but is more dangerous than with methicillin-sensitive SRAs. In most cases, your community-acquired MRSA causes mild infections of the skin and soft tissue, manifesting as boils, impetigo, and so forth. However, community-acquired MRSA also cause more serious infections, which would include our necrotizing fasciitis, severe necrotizing pneumonia, and severe sepsis. Fortunately, these invasive infections are relatively rare. On the other hand, infections of the skin and soft tissue are now common, with community-acquired MRSA accounting for more than 50% of the S. aureus isolates from these sites. Community-acquired MRSA transmission is by skin-to-skin contact and by contact with contaminated objects, including frequently touched surfaces, sports equipment, and personal items, such as razors. In contrast to your healthcare-associated MRSA infections, community-associated MRSA infections are seen primarily in the young, healthy people with no recent exposure to healthcare facilities. Individuals at risk include athletes in contact with sports, men who have sex with men, and people who live in close quarters, such as family members, child care clients, prison inmates, military personnel, and college students. Several measures can reduce the risk for community-acquired MRSA transmission. Topping the list is good hand hygiene, washing with soap and water, or applying an alcohol-based sanitizer. Other measures include showering after contact sports, cleaning frequently touched surfaces, keeping infected sites covered, and not sharing towels and personal items. Treatment depends on the infection severity. For boils, small abscesses, and other superficial infections, surgical drainage may be all that is needed. For more serious infections, drugs may be indicated. Preferred agents are the trimethoprim sulfamethoxazole, minocycline, doxycycline, and clindamycin. Alternative drugs include vancomycin, daptomycin, and linezolid, which should be reserved for severe infections and treatment failures. To eradicate the carrier state, intranasal application of a topical antibiotic, mupirocin, or ridipumulin can also be effective. Similar to your healthcare-associated MRSA, community-acquired MRSA does not respond to beta-lactam antibiotics, except ceftaroline. So, now we can talk a little bit about the chemistry. All of the penicillins are derived from a common nucleus, which is the 6-aminopenicillinic acid. This nucleus contains a beta-lactam ring joined to a second ring. The beta-lactam ring is essential for antibacterial actions. Properties of individual penicillins are determined by additions made to the basic nucleus. These modifications determine the affinity for PBPs, resistance to penicillinases, ability to penetrate the gram-negative cell envelope, resistance to stomach acid, and lastly, the pharmacokinetic property. So, the classification, therefore. The most useful classification of penicillins is based on antimicrobial spectrum. When classified this way, the penicillins fall into four major groups: narrow-spectrum penicillins that are penicillinase sensitive, narrow-spectrum penicillins that are penicillinase resistant, such as your anti-staphylococcal penicillins, your broad-spectrum penicillins, so your aminopenicillins, and the fourth would be the extended-spectrum penicillin, your anti-pseudomonal penicillins. The following table on 69.1 lists the members of each group and their principal target organism. So it's an excellent spot here to hit pause, just to kind of take a look and see which kind of penicillin class or which specific drug may be used clinically against an antimicrobial specimen. Bringing us now to our properties of individual penicillins. Starting us off is our penicillin G. also known as benzyl penicillin, which was the first penicillin available and will serve as our prototype for the penicillin family. This drug is often referred to as simply penicillin. Penicillin G is a bactericidal to a number of gram-positive bacteria as well as some gram-negative bacteria. Despite the introduction of newer antibiotics, penicillin G remains the drug of choice for many infections. So, our antimicrobial spectrum, therefore, penicillin G is active against most gram-positive bacteria, except penicillinase-producing staphylococci, gram-negative cocci, anaerobic bacteria, and spirochetes. With few exceptions, gram-negative bacilli are resistant. Although many organisms respond to penicillin G, the drug is not considered a narrow-spectrum agent compared with some of the other members of the penicillin family. So, its therapeutic use. Penicillin G is a drug of first choice for infections caused by a sensitive gram-positive cocci. Important among these are pneumonia and meningitis caused by Streptococcus pneumoniae, pharyngitis caused by Streptococcus pyogenes, and infectious endocarditis caused by Streptococcus viridans. Penicillin is also the preferred drug for those few strains of S. aureus that do not produce penicillinase. Penicillin is a preferred agent for infections caused by several gram-positive bacilli, specifically gas gangrene, tetanus, and anthrax. Penicillin is also the drug of first choice for meningitis, which is caused by N. meningitidis. Although once the drug of choice for gonorrhea, penicillin has been replaced by ceftriaxone as the primary treatment. Penicillin is now limited to infections caused by non-penicillinase-producing strains of N. gonorrhea. Penicillin is the drug of choice for syphilis, an infection caused by the spirochete T. pallidum. In addition to treating active infections, penicillin G has important prophylactic applications. The drug is used to prevent syphilis in sexual partners of individuals who have this infection. Benzathine penicillin G is employed for prophylaxis against recurrent attacks of rheumatic fever. Treatment is recommended for patients with a history of recurrent rheumatic fever and for those with clear evidence of rheumatic heart disease. Penicillin is also employed for prophylaxis of bacterial endocarditis. Candidates include individuals with a prosthetic heart valve, most congenital heart diseases, acquiring valvular heart disease, a mitral valve prolapse, and a previous history of bacterial endocarditis. For the prevention of endocarditis, penicillin is administered before dental procedures and other procedures that are likely to produce a temporary bacteremia. So, it's pharmacokinetics. Starting us off with that absorption. Penicillin G is available as 4 salts: potassium penicillin G, procaine penicillin G, benzathine penicillin G, and finally sodium penicillin G. These salts differ with respect to the route of administration and time course of action. With all forms, the salt dissociates to release penicillin G, which is the active component. Intramuscularly, all forms of penicillin may be administered by the intramuscular IM route. However, it is important to note that the different salts are absorbed at very different rates. So, as indicated in the following figure 69.3, absorption of potassium and sodium penicillin G is considered rapid. Your blood levels peak in about 15 minutes after the injection. In contrast, the procaine and benzathine salts are absorbed slowly and therefore are considered repository preparations. When benzathine penicillin is administered by an IM injection, penicillin G is absorbed for weeks, producing a blood level that is persistent but very low. So consequentially, this preparation is useful only against highly sensitive organisms, such as our T. pallidum, the bacterium that causes syphilis. So here's that figure that I was talking about. So it's a good spot to hit pause just so you can kind of see the duration of the effect for different, I guess, penicillin G IM injections. So now we can talk about the distribution. Penicillin distributes well to most tissues and body fluids. In the absence of any kind of inflammation, the penetration of the meninges and into fluids of joints and the eyes is still considered poor. By contrast, in the presence of inflammation, entry into cerebrospinal fluid, joints, and eyes is enhanced, permitting treatment of infections caused by susceptible organisms. Its metabolism and excretion. Penicillin undergoes a minimal metabolism and is eliminated by the kidneys, primarily as the unchanged drug. Renal excretion is accomplished mainly, up to 90%, by the active tubular secretion. The remaining 10% results from your glomerular filtration. In older children and adults, the half-life is actually pretty short, usually about 30 minutes. Renal impairment, however, can cause the half-life to increase dramatically and may necessitate a reduction in dose. In patients who are at high risk for toxicity, so any patient that has renal impairment, the acutely ill, and the very young or older adults, kidney function should be monitored prior to treatment. Side effects and toxicities. Penicillin G is the least toxic of all antibiotics and is among the safest of all medications. Allergic reactions, the principal concern with penicillin, will be discussed a little later. Other reactions, though, could include pain at the site of an IM injection, prolonged sensory or motor dysfunction after accidental injection into a peripheral nerve, and neurotoxicity, which would be our seizures, confusion, and hallucinations. If our blood levels start to climb too high, inadvertent intra-arterial injection can produce severe reactions. Again, that gangrene, necrosis, sloughing of tissue, and that must be avoided at all costs. Certain adverse effects may be caused by compounds co-administered with penicillin. So, for example, the procaine component of procaine penicillin G may cause bizarre behavioral effects when procaine penicillin is given in large doses. When large IV doses of potassium penicillin G are administered rapidly, hyperkalemia may result, which could potentially cause dysrhythmias and cardiac arrest. Similarly, the use of IV sodium penicillin G may lead to an electrolyte imbalance. Sodium penicillin G should be used with caution in patients, especially those who are on a sodium-restricted diet. So, speaking on penicillin allergies, are general considerations. Penicillins are the most common cause of a drug allergy, anywhere between 0.4 and 7% of patients who receive penicillin experience some type of allergic reaction. Severity can range anywhere from a minor rash, but can be as severe as a life-threatening anaphylaxis. As with most allergic reactions, there is no direct relationship between the size of the dose and the intensity of the response. Although prior exposure to penicillins is usually required for an allergic reaction to occur, responses may occur in the absence of a prior penicillin use, because patients may have been exposed to penicillins produced by fungi or to penicillins present in food or of animal origin. Because of that kind of cross-sensitivity, patients allergic to one penicillin should be considered allergic to all penicillins. In addition, a few patients display cross-sensitivity to cephalosporins. If at all possible, patients with a penicillin allergy should not be treated with any member of the penicillin family. Use of cephalosporins depends on the intensity of allergic response. If the penicillin allergy is mild, use of cephalosporins is considered probably safe. However, if an allergy is considered severe, cephalosporins ought to be avoided as well. Individuals allergic to penicillin should be encouraged to wear a medical identification bracelet to alert healthcare personnel of their allergy. So that brings us kind of to the different types of allergic reactions. Penicillin reactions are classified as immediate, accelerated, or delayed. An immediate reaction occurs 2 to 30 minutes after the drug is administered. Accelerated reactions occur within 1 to 72 hours, and a delayed reaction occurs within days to weeks. Immediate and accelerated reactions are mediated by immunoglobulin E antibodies. Anaphylaxis is an immediate hypersensitivity reaction mediated by IgE. Anaphylactic reactions occur more frequently with penicillins than with any other drug. However, even with penicillins, the incidence of anaphylaxis is extremely low. Nonetheless, when the reactions do occur, the risk for mortality is high. The primary treatment is epinephrine and respiratory support. To ensure prompt treatment if anaphylaxis should develop, patients should be observed for at least 30 minutes after drug injection. The development of penicillin allergy. Before discussing penicillin allergy further, we need to review development of allergy to small molecules as a class. Small molecules such as penicillin and most other drugs are unable to induce antibody formation directly. Therefore, to promote antibody formation, a small molecule must first bond covalently to a large molecule, usually a protein. In these combinations, the small molecule is referred to as the hapten. The hapten-protein combination constitutes a complete antigen that stimulates antibody formation. The hapten that stimulates the production of penicillin antibodies is rarely intact penicillin itself. Rather, compounds formed from the degradation of penicillin are the actual cause. So as a result, most penicillin antibodies are not directed at penicillin itself. Rather, they are directed at the various penicillin degradation products. Skin tests for penicillin allergies. Allergy to penicillin can decrease over time. Therefore, an intense allergic reaction in the past does not necessarily mean that an intense reaction will occur again. In patients who have a history of a penicillin allergy, skin tests can be employed to assess current risk. These tests are performed by injecting a tiny amount of the allergen intradermally and observing for a local allergic response. A positive test indicates the presence of IgE antibodies, which can mediate severe penicillin allergy. Accordingly, if skin testing is negative, a severe allergic reaction is unlikely. It's important to note that skin testing can be dangerous. In patients with severe penicillin allergy, the skin test itself can precipitate an anaphylactic reaction. So, accordingly, the test should be performed only if epinephrine and facilities for respiratory support are within immediate availability. Current guidelines recommend that skin testing with two reagents, which test for the major and minor determinants of a penicillin allergy. The minor determinants, although less common, mediate most severe penicillin reactions. The major determinant reagent, available commercially as prepen, contains a single component, which is that benzyl penicillyl polylysine. That is a large polymeric molecule that is poorly absorbed. Therefore, even in patients who have a severe penicillin allergy, the skin test carries a low risk for a systemic reaction due to the fact that it is poorly absorbed. The recommended minor determinant reagent, which is not available commercially, just FYI, is a mixture of three compounds. It's the benzyl penicillin G, benzyl penicilliolate, and a penicillionyl propylamine. So again, as noted, the term minor indicates that the antibodies being tested for are relatively uncommon, and not that the allergic response mediated by these antibodies is of minor significance. In fact, the minor determinants are responsible for the most severe penicillin reactions. So that brings us to the management of patients with a history of a penicillin allergy. All patients who are candidates for penicillin therapy should be asked if they have a penicillin allergy and what their reaction is or was. For patients who do answer yes, the general rule is avoid penicillins. If the allergy is mild, a cephalosporin is often an appropriate alternative. However, if there is a history of anaphylaxis or some other severe allergic reaction, it's prudent to avoid cephalosporin as well. When a cephalosporin is indicated, an oral cephalosporin is preferred. For many infections, vancomycin, erythromycin, and clindamycin are effective and safe alternatives for patients who have a penicillin allergy. Rarely, a patient with a history of anaphylaxis may have a life-threatening infection, for which alternatives to penicillin are ineffective. In those cases, the potential benefits of penicillin therapy outweigh the risk, and treatment should be instituted. To minimize the chances of an anaphylactic reaction, penicillin should be administered according to a desensitization schedule. In this procedure, an initial small dose is followed at 60-minute intervals by progressively larger doses until the full therapeutic dose has been achieved. It should be noted that the desensitization procedure is not without risk. So, accordingly, epinephrine and facilities for respiratory support need to be immediately available. Which brings us to the patient-centered care across the lifespan on penicillins. It's an excellent spot to pause so you can review the different lifespans in regards to penicillins. So that brings us to that last little section for penicillin G, the drug interactions. Bacteriostatic antibiotics. Because penicillins are most effective against actively growing bacteria, concurrent use of bacteriostatic antibiotics, which would be our tetracycline, could, in theory, reduce the bactericidal effects of the penicillin. However, the clinical significance of such an interaction is not known. Nonetheless, combined use of penicillin and a bacteriostatic agent should be avoided. Bringing us to penicillin V, or 5. Penicillin V, also known as penicillin VK, is similar to penicillin G in most respects. The principal difference is acid stability. Penicillin V is stable in the stomach acid, whereas penicillin G is not. Because of its acid stability, penicillin V has replaced penicillin G for pretty much all oral therapy. Penicillin V may be taken with meals. Penicillinase-resistant penicillins. By altering the penicillin side chain, the pharmaceutical chemistry have created a group of penicillins that are considered highly resistant to inactivation by beta-lactamases. In the US, 3 such drugs are available: nafcillin, oxacillin, and dicloxacillin. These agents have a very narrow antimicrobial spectrum and are used only against penicillinase-producing strains of Staphylococci. Because most strains of Staphylococci produce penicillinase, the penicillinase-resistant penicillins are drugs of choice for most staphylococcal infections. It should be noted that these agents should not be used against infections caused by non-penicillinase-producing staphylococci, because they are less active than penicillin G against these bacteria. An increasing clinical problem is the emergence of staphylococcal strains, referred to as MRSA, a term used to indicate the lack of susceptibility to methicillin and all other penicillinase-resistant penicillins. Resistance appears to result from the production of PBPs, to which the penicillinase-resistant penicillins cannot bind. Vancomycin is therefore the treatment of choice. Which brings us to nafcillin. Nafcillin is usually administered by the IV route. IM is considered rare. Absorption from the gastrointestinal tract is erratic and incomplete, and therefore oral formulas have been discontinued. Bringing us now to oxacillin and dicloxacillin. Both are similar in structure and pharmacokinetic properties. Both are acid stable, but only dicloxacillin is formulated for oral dosing. Oxacillin is administered via IV. Bringing us to our broad-spectrum penicillins, or aminopenicillins. Only 2 broad-spectrum penicillins are considered available at this time: ampicillin and amoxicillin. Both have the same antimicrobial spectrum as penicillin G, plus increased activity against certain gram-negative bacilli, including the Haemophilus influenza, E. coli, and Salmonella and Shigella species. This broadened spectrum is due in large part to an increased ability to penetrate the gram-negative cell envelope. Both drugs are readily inactivated by beta-lactamases and therefore are ineffective against most infections which would be caused by S. aureus. So if we're talking specifically on ampicillin, ampicillin was first broad-spectrum penicillin in clinical use. The drug is useful against infections caused by Enterococcus faecalis, Proteus mirabilis, and E. coli, but also including Salmonella and Shigella and H. influenza. The most common side effects would be our rash and diarrhea, both of which occur more frequently with ampicillin than with any other penicillin. Administration can be oral or IV, but it should be noted that for oral therapy, amoxicillin is preferred. Dosages for patients with a normal kidney function are shown in the following table. For a patient with renal impairment, again, keep in mind dosage should be reduced. So here's that spot where you should pause so you can see different dosages for penicillins. Again, as discussed later, ampicillin is also available in a fixed-dose combo drug with sulbactam, an inhibitor of the bacterial beta-lactamase. The combination is sold as unison. Which brings us to amoxicillin, or moxitag, which is similar again to ampicillin in the structure and action. The drug, however, differs primarily in its acid stability, amoxicillin being more acid stable. Therefore, when the two are administered orally in equivalent doses, your blood levels of amoxicillin are actually greater. Accordingly, when oral therapy is indicated, amoxicillin is the drug of choice. Amoxicillin produces less diarrhea than ampicillin, perhaps because less amoxicillin remains unabsorbed in the intestine. So, as discussed later, amoxicillin is also available as a fixed-dose combo drug with clavulanic acid, which is the inhibitor of the bacterial beta-lactamase. The combo drug is marketed as Augmentin. Amoxicillin by itself is one of our most frequently prescribed antibiotics at this time. Which brings us to our extended spectrum penicillins, our anti-pseudomonal penicillins. Only one extended spectrum penicillin is available, and that is our piperacillin. The antimicrobial spectrum of piperacillin includes organisms that are susceptible to the aminopenicillins plus Pseudomonas aeruginosa, Enterobacter species, Proteus species, Bacteroides fragilis, and many Klebsiella species. This extended spectrum penicillin is susceptible to beta-lactamases and therefore is ineffective against most strains of S. aureus. Piperacillin is used primarily for the infections with P. aeruginosa. These infections often occur in the immunocompromised host and can be very difficult to eradicate. To increase the killing of Pseudomonas, an anti-pseudomonal aminoglycoside may be added to the regimen. When these combinations are employed, the penicillins and the aminoglycosides should not be mixed in the same IV solution. Again, because of the high concentration of penicillins, they can inactivate aminoglycosides. So, if we're speaking specifically on piperacillin, piperacillin again has a broad antimicrobial spectrum. However, the drug is penicillinase sensitive. Penicillin is highly active, again, against P. aeruginosa, its principal target. Piperacillin can cause bleeding, secondary due to the disrupted platelet function. The drug is acid labile and therefore must be administered parenterally, usually via IV route. Dosage for patients with normal kidney function are shown in Table 69.2. Dosages should be reduced in patients who have renal impairment. Again, as discussed later, piperacillin is also available as a fixed-dose combo drug with tazobactam, which is the beta-lactamase inhibitor. The combination is marketed as Sosin, which is very common and popular today. Penicillins combined with a beta-lactamase inhibitor. As their name indicates, beta-lactamase inhibitors are the drugs that inhibit bacterial beta-lactamases. By combining a beta-lactamase inhibitor with a penicillinase-sensitive penicillin, we can extend the antimicrobial spectrum of the penicillin. In the US, 3 beta-lactamase inhibitors are being used: sulbactam, tazobactam, and clavulanic acid. These drugs are not available alone. Rather, they are available only in a fixed dose combo with penicillin. 4 such combination products are available: ampicillin sulbactam, also known as Unison; amoxicillin clavulanate, also known as Augmentin; piperacillin and tazobactam, also known as Sosin. Because the beta-lactamase inhibitors have minimal toxicity, any adverse effects that occur with the combination products are due to the penicillin within. Completes our chapter here for today. I thank you as always for listening, and you have a wonderful rest of your day.